Good evening, ladies and gentlemen. Welcome to this subject seminar on melanoma. Because of all these conferences and things like that, we have not met very often this month, and it's nice to have a class back on its tracks. And I hope from now on, we will have regular teaching in the Sagar Aster program. Let me especially welcome all the seniors here. I see Ravi, I see Ramakrishna, Shivram, and welcome to all of you. I do hope some more will join again. Melanoma is an important topic, both because of the exam, from the exam point of view, where many times they keep asking you questions on melanoma, and also in practice, and in terms of the classification, I think melanoma has a special role. Certain definitions are important, and Pavan is going to talk about those things. And historically, it will be interesting to know that the concept of sentinel node, in fact, started with melanoma. All right. So here I'm giving it over to Pavan to give his presentation on malignant melanoma. Over to you, Pavan.
Thank you, sir. Good evening to everyone. I'm Dr. Pavan, first year DNB resident from Sagar Hospital. Today, we will discuss on malignant melanoma. As we all know that melanocytes are the pigment producing cells which are embryologically derived from the neural crest cells, and melanocytes are present in the stratum basale of the epidermis. So melanocytes are, as the melanoma is a cancerous condition which is arising from the melanocytes, which is seen in skin, mucosa, retina, and the leptomeninges. The table in the slide show various sites of melanoma in our body and their percentages as shown in the table, starting from the head and neck to other sites. Malignant melanoma accounts for 5% of the skin malignancies, and it is responsible for the over 75% of the skin cancer related deaths. And malignant melanoma is most commonly seen in the younger adults in 20 and in second and third decades. The distribution between the sexes varies around the world, and malignant melanoma reflects occupational and recreational exposure to sunlight. Pathophysiology, that is, a small portion of the malignant melanoma is genetically mediated, and they are presented in the earlier ages. UV exposure favors the development of lentigo maligna melanoma, which is a type of malignant melanoma in presence at the later onset of the disease. Flash fry exposure holiday tans favors the various other varieties of morphological variants of malignant melanoma, which are early in onset of the disease. The risk factors for the malignant melanoma, that is genetical syndromes like dysplastic Nevi syndrome and congenital giant melanoma syndrome, and past history of malignant melanoma, any family history, and individuals having more than 30 sun-acquired nevi, and having history of 5 significant sunburns before the age of 16, people who are close to the equator and fair-skinned individuals, and excessive exposure to ultraviolet rays, and the individuals who are having immunosuppressions have a high risk of developing malignant melanoma to 20 to 30 times. As we discussed in the previous slide, that ultraviolet exposure is the high risk factor for the developing of malignant melanoma. The ultraviolet A radiations, it penetrates into the deeper part of the dermis, and it induces changes in the dermal connective tissue and loss of skin elasticity. Whereas in ultraviolet B rays, which causes sunburns and increased melanin production. So both ultraviolet A and B are carcinogens. coming to Clark's concept, two phases of growth of malignant melanoma. The initial phase is the radial growth phase, and the later phase is the vertical growth phase. In the radial growth phase, the tumor cells proliferating horizontally at the dermo-epidermal junction, and the tumor cells are confined to the epidermis and the superficial part of the dermis. Whereas in the vertical growth phase, the tumor cells are inverts deeper into the dermis. So development of that leads to development of the palpable nodules, the type of palpable nodules like nodular melanoma, which is a type of malignant melanoma. So this image showing stages of development of the malignant melanoma, starting from a benign nevus to a fully blown metastatic melanoma. Starting from benign nevus, which is a benign condition, to melanoma spreading to distant sites like lungs, liver, and brain. As the melanoma arises from the normal pigmented skin, or melanoma may develop from the pre-existing nevi from 22 to 10 to 20% of the malignant melanomas. And most likely nevi which forms malignant melanoma are atypical nevi, atypical junctional lentiginous nevi, and giant pigmented congenital nevi. Melanomas are most commonly presented as...
One sec, Pavan. I'll stop you here.
Yes, sir.
And then take one or two questions. Dr. Srikanth asks, why is UVC, ultraviolet C, why is it not carcinogenic?
So the wavelength of the ultraviolet rays is more.
Yeah,
sir.
I don't know the answer. Srikanth, do you know the answer? Anybody else who knows the answer?
Because the ultraviolet rays is filtered by the ozone layer. It does not reach the environment.
I see. What if there is a hole in the ozone layer?
That is the risk of ozone depletion.
Yeah. Okay. So, but when if and when it does reach the skin, it is carcinogenic. Is that correct?
Yes, sir.
All right. Okay. A fundamental question to our students here. We keep talking about anaplasia, dysplasia, metaplasia, things like that. In pathological terms, what do they mean to you? What is metaplasia? You talked about dysplastic nevus. That's why I got this simple thought in my mind. Can I ask Janani? Janani, what is metaplasia? What is dysplasia and what is anaplasia?
Sir, differentiation of one particular cell type into other type. Like, for example, the ciliated epithelium becoming columnar, or it is transforming into another cell type.
Okay.
Yes, sir. That is metaplasia.
Okay.
Dysplasia is the arrangement of the particular type is changed, sir. That is the prior to metaplastic change. The cells will be
prior to metaplasia. No.
Yes, I'm not sure, sir. Then
who else? Saurabh, can you take that?
Yes, sir. Sir, in metaplasia, there is
metaplasia.
Usually that
no. She has one adult type, another type, and another adult
okay,
type
sir.
of epithelium. That is given. What about dysplasia and anaplasia?
So dysplasia is where the cell type changes to less differentiated form, sir.
Agreed.
So it is a early stage of final malignancy, sir.
Is it an early stage or a pre-malignant condition?
Pre-malignant stage, sir.
Pre-malignant. Dysplasia yes, then goes on to anaplasia, which is the description of malignancy. So what is the difference between dysplasia and anaplasia?
So I'm not sure, sir.
Think. What happens in cancer doesn't happen in cancer? By definition.
Sir, there will be unregulated reproduction of cells in malignancy.
What is the hallmark of cancer? Metastasis, man.
Yes. Okay.
Dysplastic epithelium doesn't metastasize. Anaplasia does metastasize. That's why it becomes cancer. All right?
Okay. Yes.
Okay. And there's another question, ugly duckling sign. What is it?
Sir, usually melanoma will have when it will have an irregular looking shape, different in color or shape compared to the other nevus in the body. That is what we call ugly duckling sign. That
are you happy
that
with
usually,
that answer, Srikanth?
It is not melanoma. Yeah. When the patient is having multiple pigmented nevi, the one which is different from the other is called duckling sign.
Correct. That is the most likely to be malignant.
Malignant.
yes.
Yes. Okay.
What is
Continue.
amelanotic melanoma?
So which doesn't have any pigments, are usually pink colored it will be, and it has got aggressive course, sir.
Yes, that's correct. All right, Pavan, please continue.
Okay, sir. As the malignant melanoma is most commonly present as a cutaneous disease, the clinical characteristics of malignant melanoma as having a asymmetrical outline with irregular border with a change of color variations, having diameter greater than 6 mm with elevations like ulcerations and all. The other clinical characteristics like enlarged or ulcerated pigmented lesions and amelanotic lesions, which appears as raised pink purple skin papules having a late often have diagnosed lately. So the malignant melanoma, as I described in the previous slide, that having then asymmetric outline with irregular borders with change of color variations, having a diameter greater than 6 mm, so, macroscopic features in nevi suggesting of a malignant melanoma when there is a change in the size of the nevi or shape of the nevi or color of the nevi, like thickness, any elevations or ulcerations with satellite lesions with any itching or serosanguinous discharge. These features suggesting of a nevi transform into a malignant melanoma. So Breslow's classification, which is a prognostic indicator of the malignant melanoma until node spreads. Based on the thickness of invasion, there is a various levels of thickness, that is level 1 starting from less than 0.75 to level 4 that is more than 4 mm, which can be measured through optical micrometer. The Clark's levels of malignant melanoma starting from the level 1 involving the epidermis and level 2 extending into the papillary dermis with level 3 completely involving the papillary dermis, level 4 involving the reticular dermis, and level 5 involving the subcutaneous tissue. So coming to various types of malignant melanoma, starting from
Pavan, there is a question here.
Yes, sir.
From Dr. Ravi Shankar. Where is amelanotic melanoma commonly seen?
Over the face, sir.
Ravi, you want to come in?
Yes, head and neck.
Ravi, you want to come in? Can you unmute?
Yeah, I think it is not face. I don't think face is the thing. It's probably the GI tract, which is probably the most common site of amelanotic melanoma. That is in the perianal region, the rectum, the anal canal and rectum.
Yeah. Go ahead, Pavan. Yeah.
Coming to the superficial spreading type of melanoma, which is a type of malignant melanoma, which is commonly seen and it accounts for 70% of the malignant melanoma. It arises from the pre-existing nevus and changes over years and followed by rapid growth before the presentation. The nodularity within the superficial spreading type of melanoma declares the onset of vertical growth. It is most common, it has more radial growth and has better prognosis. Coming to nodular melanoma, it is the most aggressive type of melanoma and it has a shorter clinical course, and it is accounts for 15% of the all malignant melanomas, and it is most commonly arised as a new lesion in the skin, and it is most common in men when compared to women. It is most commonly seen in the middle age groups and commonly seen on the trunk or head and neck. So the lesions typically appears as blue or black papules of around 1 to 2 centimeters in diameter. So the lesions are sharply demarcated because they lack the horizontal growth phase, that is radial phase. And among the nodular melanoma, 5% of the lesions are amelanotic type. Lentigo maligna melanoma, which is previously known as Hutchinson's melanotic freckle. So it accounts for 5 to 10% of the malignant melanoma. So it is presenting as a slow growing tumor, and it is an variegated, and it appears as brown macule and seen on the face, neck or hands. And it is positively correlated with the prolonged and intense sun exposure. It is affecting more commonly in the women when compared to men. So lentigo maligna melanoma having less malignant potential when compared to the other variants of the malignant melanoma uh, until until it enters into the vertical growth phase. Once it enters into the vertical growth phase, the metastatic potential is similar to that of the other variants of the malignant melanoma. Acral lentiginous melanoma. The term itself indicating that the acral means it involving in the peripheries like foot and foot and palms. It is rarely seen in the white individuals. It is commonly seen in the Asian population. The lesions present as irregular macules, flat, and if the lesions are amelanotic type, if it mimics like a fungal infection or pyogenic granuloma. Amelanotic melanoma, because of the undifferentiation, tumor cells lose their capacity to synthesize melanin. So it is a rapidly progressive pinkish fleshy tumor. It has a it mimics soft tissue tumors. The tumor markers for diagnosing of amelanotic melanoma is S100 and HMB45. Desmoplastic tumor, it has an highest affinity towards the perineural invasion. It is having recurrence rate commonly seen in head and neck. It is a amelanotic melanoma with thicker lesion carrying poorer prognosis due to neural invasion. Sublingual melanoma, melanoma underlying the fingernail. It is usually some superficial spreading type of melanoma, and it is better to take the biopsy along with the nail matrix rather than the pigmented part of the nail plate. And the clinical features of the subungual melanoma, that is Hutchinson sign, nail fold pigmentation that progressively involving to produce a triangular pigmented macule with nail dystrophy. If the nail fold is uninvolved, there is a less likely of malignancy. The microscopic features, as I discussed in the previous slide, that
Pavan,
sir,
one sec.
yes,
Saurav asks, so how do you differentiate between ungual melanoma and melanonychia? Saurav, your answer?
Sir, as far as I understood, the only way is dermoscopy, sir, which will give a better differentiation of the ABCDE. And if beyond that it is still difficult to diagnose, we can go for a biopsy of that
Biopsy
site,
is
sir.
the only thing that really tells you what it is. Yes. Okay.
Yes, sir.
Continue, Pavan.
Yes, sir. The microscopic features of the malignant melanoma, as the melanocytes are present in the basal cell layers of the epidermis, so they are limited to atypical melanocytes, which are limited to the dermoepidermal junction. During horizontal growth phase, the cell spreads along the dermoepidermal junction and may reach the dermis. During vertical growth phase, the dermis may get invaded. Greater the depth of the invasion, greater the metastatic potential. The management of the malignant melanoma, a detailed history and clinical examination of the primary lesion and identification of the local and distant spreads, excision biopsy along with the 2 to 3 margins of the skin with some dermal fat is acceptable. In a case of equivocal cases, observation and review every 2 months. For serial clinical and dermatoscopic photography is mandatory when observation is chosen. Biopsy and pathological examination provide the first step for the staging melanoma. As I discussed that Breslo's thickness is the prognostic indicator in the absence of lymph nodal metastasis. Investigation should be directed in a way that which helps in making a staging of the melanoma, and the only cure for malignant melanoma is the appropriate surgery. Sentinel lymph nodal biopsy should be start from T2A or greater than T2A. Investigations for T3A disease should be directed in a way that along with the clinical presentation.
Pavan, what is your understanding?
Treatment for malignant melanoma.
Pavan,
Yes,
one
sir.
sec. Yeah.
Yes, sir.
Maybe I should direct it to somebody else. Hari, what is your understanding of incision biopsy versus excision biopsy for suspected malignant melanoma?
Sir, sorry, excision biopsy should be taken in a particular melanoma, like he mentioned, lentigo malignant melanoma, so that we can go for the extent of invasion, sir. But
suppose you have a suspected superficial spreading melanoma, would you do incision biopsy there?
No, sir. Only we should move over mostly.
Please understand, yes, be very clear in this concept. Unless you're chopping off something very, very important near the eye or something which is disfiguring, always in a suspected malignant melanoma, it is suspected, you don't even know what it is, get an excision biopsy with a reasonable margin. Then again, we talk about margins. I think there are a few slides about margins in Pavan's presentation later. But in a suspicion where you're not sure whether it is malignant melanoma or not, what would be the margin that you would give?
1 centimeter.
Excision biopsy. Yes, 1 centimeter I think is reasonable. It can be even less than that if you're again looking at something disfiguring, because it's only a suspicion. Because you can always extend, go in for a wider excision soon after the histologist comes back. Okay, so yes, it is reasonable to take about 1 centimeter away from the visible edge of the lesion. It can be even less, because you have to first warn the patient that there may be further wider excision required if the histology says it is a malignant melanoma. But yes, the principle is, unless it is something which is disfiguring or in some way really crippling the patient, you should be considering excision biopsy. Okay. Local treatment. Go on, Pavan. Continue.
The treatment for malignant melanoma is the surgery. Yes, sir.
Go on, continue.
Yes, sir. In the case of lentigo maligna, there should be complete excision of the lentigo maligna should be done because it has a higher risk of entering into the vertical growth phase to become a lentigo maligna melanoma. Before coming to the stages of the melanoma, we have to know about some terms like in-transit metastasis and the microsatellites. So, what is in-transit metastasis? It is a intra-lymphatic tumor in the skin or subcutaneous tissue more than 2 centimeters from the primary tumor, not beyond the nearest regional lymph node. Microsatellite is defined as it is a tumor nest cells greater than 0.05 mm diameter in the dermis and subcutaneous plane beneath the primary invasive tumor, which is separated from the primary tumor with at least 0.3 mm of normal tissue. So this is the satellite nodule showing the primary tumor, which is separated from the primary tumor less than 2 centimeters. So this is the in-transit metastasis, in which the in-transit metastasis which is separated from the primary tumor more than 2 centimeters and the nearer that is in between the primary and the regional lymph nodes.
Right. Pavan, one sec.
Intralymphatic metastasis.
Pavan, one sec.
Yes, sir.
Shrikant, I'm looking at your questions in the chat box. He has defined the Clark's level earlier. Perhaps you had not logged in yet at that time. And do you have any comments to make on the incisional biopsy that I mentioned about?
No. The larger lesions, more than 6 millimeter, say the incision biopsy, as you suggest, again, cosmetic areas, incision biopsy.
Okay, I had answered that. So
yeah.
there is, you do not have a different view on that.
No.
All right. Okay. Pavan, continue.
Intralymphatic metastasis characterized as clinical or pathologically detectable satellite lesions, satellite metastases, whether they are visible or microscopically cutaneous and subcutaneous lesions occurring within 2 centimeters of primary melanoma. So patients having lymph nodes with intransient disease or microsatellites are in the stage 3. The micrometastases are diagnosed after lymph nodal biopsy and complete lymphadenectomy, whereas macrometastases are defined as clinically detectable nodal metastases confirmed by therapeutic lymphadenectomy. Sorry. Coming to the TNM staging of the malignant melanoma, that is starting from T1, which is having a primary tumor size of less than 1 mm, to T4 having a size more than 4 mm. In the case of nodal involvement, starting from N0 and N1 having 1 nodal involvement, N2 2 to 3 nodal involvements, and N3. In the case of a distant metastasis, M0 with no distal metastasis, whereas M1 with skin and subcutaneous metastasis, and M1B lung metastasis, and M1C is other visceral mets.
Please note that this thing is this dimension is the depth, not the diameter.
I wanted to, that's what I wanted to mention.
Okay.
Yeah.
Right.
Sir, can I ask a question?
Please.
Pavan, what is the significance or difference between Clark's and Breslow staging? Are they different or the same, or what is the significance?
Can Hari take that question?
Sir, the Breslow classification, they say it is prognostic, sir, for melanoma cases. I don't know much of difference, but Clark's say it is less prognostic and more subjective, as they say, sir. Like level 1, this epidermis till papillary dermis. But actually, Breslow is saying...
No. Saurav, you want to take it?
Sir, I'm not sure about this answer.
Not sure. Ravi, you want to come with the answer?
Yeah, I think.
Sorry, Janani, you wanted to say that?
Sir, yes, sir. Sir, in Breslow's classification, the tumor is measured in millimeters, sir.
Yes.
So the size of the ulcer, the melanoma lesion is measured there. And in Clark's, it will it will just tell us the depth of the invasion. So both are used in TNM staging, sir.
No. That's not necessarily true. No, that's not right.
No.
Ravi, you want to come with the answer?
Yeah,
So,
I think initially, I think it was Clark staging which was there, where they describe it, in terms of the involvement of the papillary dermis and reticular dermis. But Breslow is more recent, which is probably a bit more accurate and hence, more helpful in prognosticating the disease. But if you compare the various stages, they are almost the same. But now I think Clark staging is probably not used as much as Breslow staging. And that is reflected in the T1 also, because T1, T2, T3, T4, usually measures the depth of invasion in terms of 1 millimeter to 4 millimeters.
All right, go ahead, Pavan.
Yes, sir. The recent NCCN guidelines of the malignant melanoma, stage 0, which is then melanoma in situ, having a lesion thickness of 0.75 mm with no ulcerations, and stage 1A with thickness 0.76 mm with no ulcerations, and stage 1B with thickness 0.76 to 1 mm with ulcerations, whereas the stage 2 with thickness more than 1 mm with clinically negative nodes, whereas in stage 3, clinically detectable palpable nodes with microscopic satellitosis or in-transit disease. Stage 4 is distant metastasis. As we discussed that the definite treatment for the malignant melanoma is the wide local excision, whereas in the case of trunk and proximal extremities, we measuring the appropriate margins around the lesion and involving the residual edges of the melanoma, and extended in a given in an incision in a manner elliptical incision approximately 3 times as long as its width. The direction of the scar in the case of extremities is longitudinal, whereas in the case of trunk and neck along the skin lines over the upper back, it is transversely.
All right, just go back on slide, Pavan.
Pavan,
please go back on slide.
Yes, sir.
What is the logic in this ellipse being 3 times longer than the width?
Sir, it involves all the margins of the lesion, sir.
Yeah, see, the first thing is you have a lesion, you go 2 centimeters around the lesion. Okay, that is approximately a circle.
Yes, sir.
All right, because most of them are circular lesions.
Yes, sir.
But then he says make it an ellipse, it's vertical in the limbs and transverse in the trunk, but make that ellipse 3 times longer than the circle that you have, which gives you the clearance. What is the logic in this 3 times business?
Yes.
Understand that, just don't mug it up. That's my point. Saurav.
So I don't know this, sir, actually.
Hey, you have attended my basic skills course long ago.
Sir,
you must have forgotten.
So for skin approximation, is it? I'm not sure, sir.
It's the same principle as in any wound here, even if it's a traumatic wound. You want a tension-free wound.
Yes, sir.
Without excessive undermining that gives you ischemia. So if you want to get a tension-free closure with minimal undermining, you need to have this ratio. The width must be 1/3 of the total length of the ellipse. Okay, that is a standard thing for any wound.
Yes, sir.
You understand? And also, what you have not stressed here is the depth of the lesion. Okay, whenever you take it, you must go to the subcutaneous tissue. When you excise a suspected or a proven melanoma, you must go right down to the subcutaneous tissue and excise it. You don't have to take the fascia and go even deeper, because by the time the tumor locally has gone to that depth, it will have already gone to the lymph nodes. Okay, reaching the subcutaneous tissue is enough when you do an excision for a melanoma, suspected or proven. Okay, all right.
Yeah, yes, sir.
Go on, Pavan.
Yes. Excision should include skin and the subcutaneous tissue along with the deep fascia.
Yeah.
If when there is a major cutaneous.
Go on. I hadn't remembered this particular slide. That's why I mentioned it. Go on.
When there is a major cutaneous nerve runs along the deep fascia, it is better to appropriate to preserve that nerve. The principles of surgical margins for wide excision of primary melanoma, the recommended clinical margins and the depending upon the tumor thickness as given in the table. The surgical management of the primary cutaneous melanoma, as discussed in the previous slides, depending upon the size of the lesion, we take the recommended clinical margins and recommended clinical margins. The case of regional lymph nodal involvement, the metastatic spread to regional lymph nodes is proportional to the brachyolus thickness of melanoma. So at the time of the wide excision, it is better to do elective lymphadenodal clearance for a better survival rate. So coming to sentinel lymph nodal biopsy, the sentinel lymph nodal biopsy is recommended for the patients with intermediate thickness.
Yeah.
Sir, I have a doubt regarding what he just said, sir. So he just mentioned that elective lymph nodal clearance. So is it appropriate for all stages or any particular stage he is mentioning?
Please, the first line of this slide tells you that.
Okay, sir. Okay.
Yeah. Okay, go on.
Sentinel lymph nodal biopsy is recommended to the patients with the intermediate thickness melanoma, that is T2 or more than T2. So the sentinel lymph nodal biopsy may be recommended for patients with thick melanoma, which having a potential benefits and the risk of harm.
Yeah. Please note that if it is more than
positive.
Pavan, when I talk, please stop for a bit. Okay.
Yes, sir.
Yeah. Please note,
Yes,
just
sir.
remember this: if it's more than 1 millimeter thick, you have to do sentinel lymph node biopsy. All right. And lymph node clearance, if you can get palpable nodes. If you have palpable nodes, clinically suspicion, macrometastasis, do a clearance. If you have no nodes, do a sentinel node if the lesion is more than 1 millimeter. Less than 1 millimeter, you may consider it if it's between 0.8 or 0.75 and 1. You may consider it, but it's not a must. Less than 0.75, it is not required. That's all. Simple enough to remember. Yeah, go on.
In case of positive sentinel lymph nodal biopsy, observation are optional for patients with low risk micrometastatic disease. For higher risk patients, careful observation may be considered only after discussion with the patient with potential risks and benefits. When we do sentinel lymph nodal biopsy, when we need sentinel lymph nodal biopsy, when the primary tumor size is more than 0.8 mm, or if the primary tumor size less than 0.8 mm along with ulcerations and mitosis and unknown thickness, or shave biopsy,
please,
and ambiguous diagnosis of melanotic lesions.
I'm sorry I'm interrupting you, Pavan, but you keep saying size, and
Yes,
I want
sir.
you guys to understand it is not the diameter of the lesion. It is the depth of the lesion. That is the only thing that matters. Okay, please understand that. So it's better for you to use the word depth when the depth is more than 0.8 millimeters. So
0.8 mm. Okay.
yeah.
Sir.
Okay. So
Yes,
rather than say size may be
yes,
4 millimeters, 5 millimeters diameter. But that's not what we're looking at. It's the thickness that is important. Please, all of you remember and practice it. Yeah, go on.
In transit disease, in these 5 to 8% of the melanoma patients have high risk of primary melanoma. So there is a hyperthermic regional perfusion. Melphalan is the therapeutic agent used, in which the melphalan is heated to 41.5 degrees centigrade and perfused to 60 to 90 minutes. It has higher response rate, more than 50%, which is not using nowadays.
Yeah.
The complications of in-transit diseases.
Pavan, I'll stop you here. I'm sorry. These things have to come in the end. You know, you need to go in an orderly fashion. I'm not quite sure why you included this slide here, because you're talking about surgery. The next thing you have to talk about sentinel lymph node biopsy, how you detect it, and then talk about advanced disease. This comes in advanced disease, so we will discuss it a little later. I'll give you a little break here, and then, okay, I'll give you a little break here and then take a couple of questions.
Yes, sir.
Saurav asks, HPE stains used in detection of micrometastasis. What is the answer, Saurav?
Sir, S100 and HMB45, sir.
Is it a stain? It's not a stain. It is an immunohistochemistry.
Okay, sir. Okay.
It is not a stain. Okay, stain is usually hematoxylin eosin only.
Okay, sir. Okay.
What you're talking about is IHC. And Dr. Ravi Shankar asks, how do you plan SLND if you have done excisional biopsy? I think he will talk about it a little later. You are talking about SLND, right?
Yeah, yeah.
Pavan?
Yes, sir.
We'll wait until he finishes that.
Yeah. Okay.
Is shave biopsy indicated in melanoma? Pavan, what's your answer? You don't know, not indicated. Okay, somebody doesn't suspect melanoma, does a shave biopsy. Okay, otherwise, even with the remote suspicion of melanoma, you should avoid a shave biopsy and do, as I told you, an excisional biopsy. Yeah, I will have given you the answer. You must think and answer. Don't say I don't know. It's easy to say I don't know. Think. You guys must be thinking. Okay.
Pavan, sir is stressing on the depth and depth and depth so many times.
Yes,
so how can you do a shave biopsy?
Shave biopsy. Okay, please think about this. All right.
Yes,
okay. Let me invite some comments from our teachers here if they want to add anything. And Shivram, you want to add anything to what has been said so far? Shivram there? I saw him log in. All right, Ravi, you want to add something?
No, I think so far, I think so kind of cleared everything.
Okay. Ramakrishna?
Nothing, sir. Nothing. Just hearing.
Okay. Shrikant?
Nothing, sir. Good. All but right. Is it necessary to remember staging in depth? How can anyone remember that?
No, I have always said I never ask students in the exam. I never even expect people to remember. They must know that depth is important.
That's all. Stage 1, stage 2.
They must know that it must be an excision biopsy. The excision must go right down to the subcutaneous tissue. That is important. And then they have to look at the books to know what the stage is. And then they will decide whether to do an SLND or not. That's the question that Ravi asked. This is simple. In practical terms, it's very simple. What you do in a clinic when you see a melanoma, okay? It has to be an excision biopsy. Yeah, go on.
Sir, he gave one term that in greater than 4 millimeters, we have to discuss SLND risk and benefits. What does he mean by that line? I didn't understand.
I don't think he said that. I don't think he said that.
Okay.
I don't think
go to the previous slide. Let us see.
Yeah.
Go to the previous slide. More. So this one, last.
Yeah.
So a biopsy may be recommended for patients with thick melanomas after discussing potential risk and harm. So this I didn't understand.
He will come to that. You see, for any procedure that you do, you have to, it's an informed consent process. There's nothing beyond that. You understand? It's an informed consent. You would recommend for anything which is thick, anything which is more than 1 millimeter, you would recommend an SLND. And when you say that, you would tell them you need to understand the pros and cons, which will be discussed in future slides.
Okay,
The patient says, I don't want it. It is left to him. And in the pros, you tell him that the mortality of the disease is less when there is an SLND done, and if it is positive, a lymph node clearance is carried out. If he says, no, I will wait until I get clinically positive nodes, I don't want an SLND now, it is his choice, but you can tell him that the prognosis is worse. For that, he has to pay the price of SLND, and what that price is, we will know in the subsequent slides. Please carry on. Please carry on. Now, what about your slides on SLND, Pavan? You need to go a little further down. You added, please go on like this. You have done this. What about SLND? I thought I saw slides on SLND, how you do it and where you do it and what you do afterwards. Do you have that information or not in a slide?
Sorry, this is only, sir.
This is the only thing you have. Okay.
Sentinel lymph nodal biopsy.
Yeah. Okay.
Yes,
but I
sir.
thought you had a slide on what you do there. Okay. Tell me, even if you don't have a slide, tell me what you do in an SLND biopsy. How do you do an SLND?
Sir, sentinel lymph nodal biopsy should be done when the thickness of the lesion is...
Don't go there. How do you do it? We have already discussed that. Please don't repeat it. How do you do it?
Sir,
Sir, radioactive dye or blue dye injected around the primary lesion, sir.
Is it around the primary lesion or elsewhere in the foot? In the breast, it is in the primary lesion. In the foot, where can you put it?
Not sure, sir.
You can put it in the web space, okay?
Okay, sir.
Okay, and then?
And then we can trace that lymph node. It's blue stained or with the gamma camera. Also
correct.
It, okay. So with that, we have to send
which group of lymph node would you normally expect to find the sentinel node to be in?
So based on the site of the lesion, sir.
Anywhere in the lower limb or on the foot?
So it's inguinal, sir.
Where? Which part of inguinal? That's what I'm asking.
Superficial inguinal group, sir.
The vertical group of the superficial inguinal nodes. Okay, that's where you expect to find it. So if you do find the gamma activity there, you take it out and send it for a histology frozen section. And if they find that node to be involved, you go ahead with a lymph node dissection, clearance, formal clearance. If it is negative, you do nothing more. Okay, that is about SLND.
Yes, sir.
All right. Next, we go on to other areas where it is advanced disease. Go on now with your other slides.
Sir, my doubt is, very basic. I don't know the answer to this. That's why I asked that question. See, now you have done an excision biopsy already.
Yes.
Because you have to decide whether you have to do SLND or not.
Yes.
So if you have already done the excision biopsy, then how are you going to, do because in case of breast, you actually inject the lesion so that you know which is the sentinel node.
Yes.
Here, how will you know that? Because you already excised the lesion.
This is the point, that you don't have to be perilesional. You just want to know from the lower limb. Put your dye into the web space.
Okay.
Into the web space.
Okay.
And you see, for any lesion, the first node will be where that area drains, not the specific lesion drains.
Okay.
So you can even put it in the web space, and then the first node that lights up is a sentinel node.
Right. Okay. So
it
even
need not be intra or perilesional for lower limb lesions, like the breast lesion. Yeah. Okay. All right. Go on, Pavan.
The malignant.
You skip the in-transit and you go to the in-transit disease.
Yeah, his order has changed from what I saw earlier. Anyway, go on, Pavan. You do that, yeah.
In-transit disease. 5 to 8% of the melanoma patients have high risk of primary melanoma. Hyperthermic regional perfusion, in which melphalan is the chemotherapeutic agents used. The melphalan is heated at 41.5 degrees centigrade and perfused for 60 to 90 minutes. It has high response rate, more than 50%. The complications of the hyperfusion, regional perfusion, hythermic regional perfusion is neutropenia, amputation, and death. And TNF, along with the TNF alpha or interferon alpha with melphalan, regression rate is 90%.
What is the basis of this treatment? I don't know. Why it should be to 41.5? How is it given, intravenous, subcutaneous, intramuscular, or intralesional?
Sir, this is in the case of in-transit disease. Sir,
Yeah, in-transit disease only. How it is given? What is the basis to heat to 41.5 degrees?
Heat itself is this is the heat itself can kill cancer cells. So it's when it is heated to 40 degrees, all the agents, chemotherapeutic agents and other agents like interferons, they have a higher response rate when the infusion is heated. And the whole body cannot be heated, so it's probably better to do an isolated limb perfusion. So only that limb is heated. It can also have a higher concentration of the chemotherapeutic agent so that you don't have a systemic spread and systemic toxicity. That is the principle of hyperthermic treatment. It's also used, as you know, in diffuse peritoneal metastasis.
Yeah. IPAC.
Yeah. Okay, go on, Pavan.
As a malignant melanoma is a radio-resistant tumor, the chemotherapy what we are using in malignant melanoma is the dacarbazine, which is the drug of choice, and other drugs like cisplatin, paclitaxel, docetaxel, temozolomide is also used. The adjuvant chemotherapy, when the actual mechanism for the various monoclonal monoclonal antibodies, like when mutation locks BRAF protein signaling to on, it affects the mutagen activated protein kinase cellular pathway, promoting initiation, malignant transformation, and tumor progression and metastasis in the 50% of malignant melanoma with BRAF V600 mutations. So the targeted therapy in stage 4 melanoma is dabrafenib or vemurafenib, which blocks BRAF protein signal action, which has a good results with metastatic melanoma. Whereas tramitinib has different action on the mutagen activating protein kinase pathway by stopping cell growth and promoting apoptosis. Whereas the combined use with dabrafenib to counter acquired tumor resistance via mutagen activating protein kinase pathway reactivating results in the having a good results in stage 4 disease.
All right. Now, what does this Greek and Latin? To me, it was Greek and Latin. So please explain to me what you understand by the things that you mentioned in the last 2 slides. What are the principles? I want you to understand principles. And the way you read it, the way you spoke, I don't think you have understood the principle. I want you to know that.
Sir, actually, BRAF gene, which regulating the cell proliferation, sir.
Yes.
Which producing BRAF protein, sir.
Yes.
Once the mutation locks the BRAF protein, there is no control over the cellular proliferation, sir.
What is the purpose of measuring the BRAF? What is the principle called? What is that phenomenon called? It is one of the latest developments in cancer treatment. Looking at a person treating a chemotherapist usually does it, medical oncologist. When he asks for a BRAF mutation to know whether it is on or off, what is he trying to understand about the tumor?
So it is whether it is aggressive tumor or low grading metastasis, low grading.
Okay, and then after that, what does he do? This is why I said you have not understood the principle. This comes
whether
under
the tumor is due to gene mutation or what.
Yes, and this is the one that comes under targeted therapy.
Targeted chemotherapy.
Please understand that. So if BRAF is positive, if it is on, he gives them certain kinds of chemotherapy and certain kinds of monoclonal antibodies. If it is off, he gives some other type.
Yeah.
So kindly understand the principle and not just copy paste and then read it out. None of us will ever remember these things after we switch off the presentation. You also won't remember. So what you must say when you have a thing like this is that this is a part of targeted chemotherapy. If BRAF protein is on, one type of monoclonal antibody is given. If it is off, they consider another type. And when they give this on the basis of targeted therapy, they get a 50% response rate. Okay, and if you're very smart, you would have also added the cost of the treatment, which comes to about $1 lakh or $1.5 lakh a month. And you have to give it for many months. And so then you give an impression, you have to get an informed consent from the patient. With a 50% response rate, would you be spending a few lakhs over the next few months? And if the patient says yes, give it to him. If the patient says no, don't give it to him. Okay, that would be the way in which you must give your presentation. Please continue.
It is like a breast carcinoma where HER positive, you give that.
Herceptin, yes.
Yeah.
Yes. Go on.
Actually, I have explained this to them in colon cancer. It is a fantastic prototype for most, the understanding of cancer that we have today.
Correct.
Because you have platelet activated growth factor, vascular endothelial growth factor, epidermal growth factor. So when you look at all these things, you can target them if they are present. Otherwise, you don't give this expensive monoclonal antibody.
Please understand, these are all very important in breast, colon, malignant melanoma, GIST, and lung cancers. Okay, these are the things that they actually choose which agent you use, chemotherapeutic agent you use, based on the mutations. Okay, go on, Pavan.
What are the indications of chemotherapy?
So when do you give chemotherapy, Pavan? Before lymph node dissection,
put it on the slide. Yeah.
After lymph node dissection, or in high risk cases,
Which
you should clarify that.
After lymph nodal dissection, sir.
You have mentioned it in one of your previous slides. Saurav,
do you know?
Sir, metastatic disease, sir.
Metastatic disease, sir.
Stage 3 and 4. Okay.
Stage 3 and 4. Yes.
Yeah. Okay. Go on.
Yes, sir. Interleukin 2 and interferons on high doses are used as immunotherapeutic agents, and BCG just now discussed that monoclonal antibodies like ipilimumab and some tumor vaccines like polyvalent melanoma vaccine and allogenic melanoma cell lysate and detox GP100 DNA vaccine, all these are used in immunotherapy.
When are these immunotherapy agents are used? Routinely?
Not routinely, sir.
Metastatic disease.
All these are used in advanced disease. Okay.
Yes, sir.
Metastatic disease, and all of them have anywhere between 20 and 50% response rates, and not beyond that. Okay.
Yes, sir.
All right. Go on.
Metastatic melanoma of unknown primary site, that is approximately 1 to 8% of the patient with melanoma presents with metastatic disease from melanoma of unknown primary site. It is most commonly seen presentation in the axillary lymph nodes followed by cervical lymph nodes. So as a metastatic melanoma of unknown primary site, an unrecognized melanoma or a treated melanoma that has been initially misdiagnosed, or a spontaneously regressed melanoma, a malignant transformation of a melanocyte that had traveled to metastatic location. In order to classify a tumor as a metastatic melanoma of unknown primary, the following features like histological diagnosis we should have to confirm, and previous biopsies and excision, and if any should be evaluated for possible diagnosis of melanoma, and less common primary sites for melanoma should be thoroughly evaluated. If the metastatic lesion involving the lymph nodes, so the drainage area of the should be thoroughly examined.
Pavan, again,
Yes, sir.
I think you have not understood this concept at all. You are just reading out the slide without understanding it.
Correct.
Yes.
Yeah. Yeah.
Can anyone make sense of what he's just said?
Okay. Hari, come on, tell me what it is.
We should
talk about principles. I always want principles. It's not makika makki, just mug up what the book says. Please understand the principles. Yeah, tell me.
So we should have the tissue diagnosis of melanoma, but we should not. We don't know where is the site. So for that, to call it unknown primary, we should have the diagnosis first of all.
Yes.
And then we should look for without looking at the less common primary site. We should not call it as unknown primary. We should have that primary site should be thoroughly evaluated also.
Yes.
And also, I'm not sure about the third point. So it should be evaluated for maybe the risk factors like sun exposed people. Everybody should be evaluated for that. Possible diagnosis is possible in these patients, so that for them we can call with the diagnosis unknown primary.
See, the matter is very simple. You have a lymph node, okay, a lymph nodal enlargement. That's what you're talking about. Unknown metastasis, unknown primary. Yes. Okay, you have a lymph node. You take that lesion out, comes back as melanoma. What do? Go in a systematic manner, like in any surgical principle. If you have a lesion at any one point, it is your duty to look at all the regional lymph nodes thoroughly. All right. For example, if you have a periumbilical lesion in the abdomen, you must look at both the axilla and both the groins. You understand? Because lymph nodes from the umbilical area, lymphatics drain to all these areas, both axilla and both groins. Like that, if you have something in the axilla, you must look at the pectoral region, the shoulder, the neck, and the back, the latissimus dorsi area. So all these primary areas have to be thoroughly examined for a possible small lesion. It could even be an amelanotic lesion. If none of that is found, then you have to go for history of possible excisions, which may be years earlier. Did you have an excision somewhere many years ago, where the diagnosis may have been missed? And finally, rarely you may get some lesion perhaps in the axilla, for example. It can be inside the breast. It's very rare, but it can happen. It need not be on the surface. All right. So if you have a groin lesion, for example, it may be in the anal canal. You may not see it. So you have to do an internal examination to make sure that you have thoroughly checked all the draining areas. If you don't find any lesion anywhere, if you don't find the history of an excision or something, then you will call it a malignant melanoma of unknown primary. Okay, it is as simple as that. If you understand these simple things, then you don't have to mug up. Okay, go on, Pavan.
Coming to the prognosis of the malignant melanoma, that is Breslo's thickness of primary tumor. It is a good prognostic indicator in the case of the if lymph nodes are not involved, and more is the mitotic index, and poorer is the prognosis, and more is the depth of the infection, more is the malignant potential. And presence of lymph nodal metastasis is the single most important prognostic index in melanoma. And number of affected lymph nodes and extranodal involvement also significant in the case of prognosis. And once the regional lymph nodes are clinically involved, 70 to 80% of the 85% of the patient will have occult distant metastasis. The patient should undergo staging evaluating with CT investigations like CT of the chest, abdomen, and pelvis, and MRI of the brain. And in the case of nodal disease, we should staging the patient in the stage 3 and treated similar to that of the stage 3 patients as non-primary melanoma. Early melanomas having a thickness less than 1 mm and non-ulcerated, and where the lymph nodes are not palpable, the patient should be followed up for every 6 months for 2 years and then annually. Whereas in the case of advanced melanomas, in which the lesions having ulcerated and in whom the lymph nodes are palpable, every 3 to 6 months follow up for 3 years, followed by every 4 to 2 months for 2 years, and then annually follow up should be needed. We already discussed
you mentioned about it. Please go to the next slide. Go to the next slide. Yeah, okay. So, Vanita, let us in the next 3 to 4 minutes learn to understand the principles and the take-home messages from this talk. Okay? So, you asked a question. Okay, just 1 sec. Before you stay, mucosal neuromas involving stomach vagina, will some Breslow thickness staging apply? No, it doesn't apply. It applies only to the skin. How the approach is changed in terms of investigation, the SLND and resection margins. The two are not related. Okay, resection margins, as we said, has to be between 1 and 2 centimeters. And when you get a Breslow's staging, Breslow's thickness, anything more than 1 millimeter, you have to offer as SLND. And depending on the sites, the positivity or negativity of SLND, you either carry out or not carry out a formal radical dissection of the lymph nodes of that area, and then work up for metastasis, and then decide what you want to do.
Yes, sir.
You got that? Yeah. Okay.
Yes. Now, give me one small dot before the take-home message.
Yes, sir.
Any role for PET scan in melanoma?
Yes, PET scan. Yes, it's always there, but it's very non-specific. It certainly is not done for screening. As I said, when you first see a melanoma, you don't get a PET scan. But if you have documented advanced disease, in terms of satellite nodules, in-transit metastasis, or involved lymph nodes, as you know, a large number of people with involved nodes will have metastasis. So at that time, a PET scan can be considered.
Thank you.
Okay. And the question about prophylactic lymph node dissection, very controversial, not done usually. That's why the concept of SLND has come. If SLND is negative, you do not do a prophylactic dissection.
Prophylactic node dissection is not done any cancers nowadays, I think.
It's
only SLND now.
SLND, nowadays, with the advent of this sentinel node, blind prophylactic dissection is not done. Okay, take home messages, Vanita.
Yes, sir. Sir, melanomas usually arise from basal layer of the basal layer, sir, of dermoepidermal junction from melanocytes, basically.
Yes.
Mostly in response to UV rays exposure, sir. That is to UVA rays, 320 to 400 nanometers.
Don't go, that's not required in take home. Okay. UV rays. Next step.
Next, Clark's level is for histological grading, sir, and Breslow's thickness is based on depth of invasion.
Both are the same. So, both are on the depth.
Yes, sir.
Yes.
Both are on the depth. Yes, sir.
Yes.
Yes, sir. And
sorry, Srikanth, you have something to say?
No, nothing.
Nothing. Go on. So both Clark's and Breslow's are on the depth. Clark's talks about the layer of the skin. Breslow's talks about the actual dimension of the depth.
Yes, sir.
Okay, go on.
And in most of the melanomas, we have to do immunohistochemistry examination also, sir, along with excision biopsy, particularly S100 and HMB45.
That's not what we said. That's not what we said. You don't necessarily have to do histochemistry all the time. You would need that when it is an amelanotic melanoma.
Melanotic melanoma.
Okay, only when you don't know that, how do you know melanocytes? With the pigment. If the pigment is not there, you are confused. That's when you need these IHC markers to call it a melanoma. Okay, next.
And how to identify whether an EY is turning to melanoma is by ABCDE examination, sir.
Correct. Go to the next one. We will not repeat it. Yeah.
Yes, sir. And in case of nodular melanomas, it will be EFG, sir. This one I have read somewhere, sir.
All right. Go on. Next.
And minimum 0.5 to 1 centimeter margin is required, sir, along with wide local excision for superficial melanomas. And based on Breslow's thickness, it might vary, sir, based on if it is around 2 to 3
you may have
mm
to go 2 centimeters beyond. Yeah.
2 centimeters and beyond.
Correct. Yeah.
So, and in cases of advanced diseases, we can go for other options like targeted therapy.
We'll talk about SLND. So if the lesion is more than 1 millimeter thick, it is better to do an SLND.
SLND, yes.
Okay. And if SLND is positive, do a radical dissection and clearance of the inguinal nodes.
Yes,
and if it is an advanced disease, which is T3 or T4, distant metastasis or in-transit metastasis or involvement of lymph nodes, what do you do?
So in transit metastasis, we have discussed about isolated limb perfusion, sir, with melphalan.
Yes.
Heating to 41 degrees centigrade.
Correct. There are various options. And what are those? Just list 4 or 5 things that we give. One, chemotherapy.
One chemotherapy.
Which is melphalan.
Yes.
We mentioned 3 or 4 other drugs that can be used.
Dacarbazine.
That's right. Dacarbazine and 2 or 3 others. Yes, that's one.
Yes,
chemotherapy. What else can we use?
Targeted therapy, sir, with the monoclonal antibody.
Okay, that can also be done. And for that, it is better to do, again, the IHC markers, and not the IHC markers, the genetic markers to know which one to use. Okay. And then?
So, and then immunotherapy.
You can use immunotherapy. Yes, you can use interferon. And then what else?
Interferon and interleukin.
Interleukins, correct. So all these can be used to treat advanced disease. Okay. Yes. All right. Closing remarks from my colleagues. Ravi?
Melanoma is a very important skin condition which with high index of suspicion, you can diagnose them. And surgery is the treatment of choice. And selective sentinel lymph node biopsy has come in a big way. I think probably that is the first lesion from where it started. And for palpable nodes, you have to do lymph node dissection. And chemotherapy and immunotherapy and hormone therapy are other adjuvant treatment with limited success.
Ramakrishna?
Sir, nothing, sir. He has covered everything, but as Dr. Ravishankar pointed out, many of the slides he has not understood, but just reading it out. Those things the PG has to avoid.
Yes.
Rest of the things are okay. Sir.
All right. Shrikant?
Sir, first year PG, huh?
Yeah.
Excellent, man. You have gone. You have read in the MCH book also, notes. Very good.
All right.
You have read DVTA notes and then presented. Very good, very good. Keep it up.
All right. Saurav, you had something to say?
Yes, sir. Actually, I'm referencing from one of Mundiatisa's recent cases. The patient had undergone wide excision for a melanoma long time back, and then he came with satellite metastasis. So that time, sir was asking me a question whether to go for lymph node dissection now or not. But sir did not want to go for lymph node dissection. So I wanted to know when to actually do in the second time if it comes with recurrence in the scar or satellite, whether that is an indication for local regional lymphadenectomy even without a palpable node, sir.
Please understand that satellite nodules in the limb upgrade your tumor to T3.
Yes, sir.
Which means you're talking about chemotherapy and systemic therapy.
Okay, sir. So, if
you do not have palpable lymph nodes in that area, I think it is not a formal lymph node dissection is not indicated.
Okay, sir. Okay.
Yeah. Okay. All right.
Thank you, sir.
Thank you very much. Thank you very much. We'll close the meeting. Well done, Pavan. But as I said, you must make an endeavor to understand what you're saying. And if you have doubts, you must ask your mentor. If you had given me a phone call and asked me for your doubts, I would have answered all those so that you would have given a more informed presentation. Okay. So it's for all the students. If you have any doubts in what you have to, what you're saying, what you have put on the slides, please ask your mentor and learn from that. Okay. Thank you and good night.
Thank you, sir.
Thank you, sir. Good night.
Yeah.